Welcome back to another masterclass here to Mind for All Seasons. Today we are exploring how to reduce or eliminate psychotropic drugs. So whether you're trying to optimize any medications that you might be taking and to take a hard look at those, or you're serving people in some sort of a long-term care setting, or maybe you're a family caregiver, I think this will be valuable to everyone. So to start, let me share with you an experience that I had last year. A long-term care administrator sent an email saying, I want to talk about my neighbor. That was her reference to this resident who has been living in that community since May of 2023. And she says he walked and danced when he first came in. He had been sent out his very first day as he did not want to be trapped in a facility. And he's got a history of PTSD. And as a veteran, she says he's declined in the 2+ years that he's been here, from walking and dancing to remaining in a wheelchair, not wanting to help people with standing. He yells out during most of his activities of daily living. He yells out at random, whether it be at a TV or person or the air. We have a sensory room that I've advised partners to utilize. His last 2 blood draws, he's refused. I've included notes on him and the 2 life stories that we have. So she gave a lot of background. And as she provided some of the background, she included medication list. And when I looked at his medications, I thought, oh, there's some real clues here. So let's walk through those clues and talk about what they tell us, because one of the overall patterns that I think is really important for any of us, whether we're looking at our own medication or that of someone that we serve, is to recognize that sometimes the medications that we're trying to reduce, things like psychotropic drugs, are actually easier to reduce if we pay attention to the other medications on the list. The other things that people are taking are sometimes clues about upstream problems, and if we pay attention to those clues, we just might get better results and have a more productive conversation with our doctor or the doctor of somebody that we're serving. So here were medications that this gentleman was taking. And it didn't stop at just one page. It went to a second page, and then it went on to another page. So when you look at a list of medications like that, you might be scratching your head saying, where do you even start? That's a lot of medications. And any of you watching this who are involved in skilled nursing or assisted living or memory care, or maybe even home care, are aware that a lot of older adults are on a lengthy list of medications. And therein lies some of the problem. Anytime someone has more than 6 prescription medications, the risk of polypharmacy goes through the roof. The likelihood that we're getting negative interactions from a bunch of different things, and that people are taking some medications to counteract the side effects of other medications, to counteract the side effects of other medications, is really elevated. So what do we start with? Well, for the purposes of our discussion today, let's consider what a psychotropic drug is in the first place. And basically, these are medications that affect the mind, emotions, and behavior. So they're used to treat things like mental health disorders, and they alter neurotransmitters in the brain. So we might be dealing with bipolar disorder or anxiety or depression. Sometimes, though, especially in older adults, they're used to try to control behavioral symptoms. And it gets really tricky in those areas. Just for fun, I asked ChatGPT the question that you see here, based on the AG Beers list, which is a list of medications that are not recommended for use in the elderly, as well as the CDC, the NIH, and available published research. Is it safe to use psychotropic medications in elderly dementia patients? Now, I knew the answer. I had an opinion on that, but I wanted to see what ChatGPT would say. And it came back with, short answer, there's no generally safe psychotropic for dementia. Most psychotropics raise meaningful risks in older adults with dementia, so guidelines say to try non-drug strategies first and reserve meds for severe distress or danger at the lowest effective dose for the shortest possible time. I think ChatGPT got it right there. I think that's good advice. So what could we do to reduce or eliminate these medications, or at least be good advocates for ourselves or for people that we're serving, and have a more productive conversation with physicians involved who are all well-meaning, trying to do the best job that they can with the available resources? I think a place to start is to recognize that a big mistake is focusing only on psychotropic drugs. If you're looking at the list of medications for the gentleman in the example that we're working through here, there are several psychotropic drugs, but a mistake would be to focus just on that. The other medications offer clues, as I mentioned, but if we're going to be truly person-centered in how we're reviewing things, we also need to focus on interpersonal and environmental factors. We need to look at all the meds. We need to look at lifestyle factors. What people are eating and whether they're sleeping well and whether they're physically active and whether they're doing anything to help manage their stress or connect with other humans are factors that matter a lot. We've talked here before in the AmFast community about the fact that dental health can have a profound effect on cognitive health and mental health. So we might want to pay attention to dental health. We need to be aware of physiological root causes. Instead of focusing on the symptom that's downstream and what medication might affect the symptom, could we move upstream and try to prevent behavior in the first place? So let's go back to this gentleman's medication list. If you look at it, on page 1, you see, oh, there's a psychotropic drug. Lexapro is an antidepressant medication. More on that to come. But let's look at the other medications. Well, the first one, simethicone, is used for gas and bloating. And if people have gas and bloating, then that means gut health problems. Atorvastatin is a common cholesterol-lowering medication, but it can come with some side effects. There are 2 different classes of statin drugs. There are lipophilic statins and hydrophilic statins. Now, those are big words, but lipophilic basically means that it has an affinity for fat. Hydrophilic means it has an affinity toward water. Well, the brain is a great big ball of fat. And some physicians and researchers feel like lipophilic statins have a greater likelihood that they will have negative cognitive effects. And we know that statin drugs in general do things like deplete coenzyme Q10, which is kind of like a spark plug in our energy production machinery. So some people have pain in their legs or they have a hard time moving. I actually have an extended family member who's tried various statins, and within 2 weeks of going on any of those statin drugs, he can hardly walk, and he's in terrible pain. It's a really bad side effect. There are warning labels on statins that they might cause cognitive problems, but some people believe that it's more likely for those cognitive problems to show up in lipophilic or fat affinity related statins than hydrophilic statins like rosuvastatin, otherwise known as Crestor. So this person's on a lipophilic statin. Maybe there's a place for a conversation with his doctor about considering trying a different statin, maybe Crestor, because it's hydrophilic. And that could be a thoughtful conversation with the doctor. What about this water pill, bumetanide, that this resident is on? Well, what's the reason that people retain water? Sometimes having elevated insulin leads to water retention. When your sugars and your insulin are up, you tend to retain more salt, which means that you tend to retain more water. And elevated insulin and sugar actually contributes to cardiovascular disease, which is another reason that you might be retaining water. So could we look more into that? Would it be a situation where maybe we have a conversation with the doctor about checking fasting insulin, checking A1C, and thinking about metabolic health? There might be some things that could be done to help this gentleman in that regard. Now, he's retaining water, and he's also having some problems urinating. He's taking Flomax, and we need to be aware that that might be negatively influencing his sleep. Perhaps there's more that could be done to help him sleep better. Maybe he needs to hydrate really well during the day, but by later in the evening, we need to cut off hydration so he's not up quite so much. If we could help him sleep just a little bit more, it might actually be helpful for his energy, for his cognition, for his overall mood. I feel pretty grumpy when I don't have a good night's sleep, and I think most of us do. So there's a clue in the fact that he's taking Flomax that we might need to spend more time focused on sleep. What about Imodium? Well, Imodium's used if you have diarrhea, and if he's got issues with loose stools, then that's suggestive of a gut health problem. And we're learning more all the time about the fact that the gut and the brain talk to each other constantly through the vagus nerve. It's a bidirectional highway. 90% of our serotonin is made in the gut. And we're learning now how that affects our mood and how that bidirectional relationship might work. But it could be that he might get better results overall if we focused on correcting gut health problems and really digging into that and exploring what might make a difference. Are there foods that he's eating that are triggering these gut health problems? Are there medications that he's taking that might be causing some of these issues? Those are all conversations that could be had with his doctor. Now, what about Lexapro itself? Lexapro is an SSRI antidepressant. And I'm not sure if you saw this research study, but in February of 2025, a paper was published that looked at antidepressant use, specifically SSRI antidepressants, and how that affects patients with dementia, like this gentleman that we're talking about in the case study. The conclusion of the researchers is that using SSRI antidepressants was associated with faster cognitive decline. And when SSRIs were dispensed in higher doses, then there was a higher risk of dementia getting really severe and people having fractures, and it was associated with all-cause mortality. That means you're at greater risk of dying. They concluded that these findings highlight the significance of careful and regular monitoring to assess the risks and benefits of different antidepressants used in patients with dementia. In short, what they were saying is, we might want to rethink using SSRI antidepressants in people with dementia, which is tricky because many people living with dementia experience depression. So what other things could we be doing that affect mood? A growing number of researchers, led by Dr. Christopher Palmer from Harvard Medical School, are of the opinion that mental health problems are a metabolic problem, that if cells are not producing good energy, you end up with mental health symptoms. We already saw in this gentleman's medication list some hints that he might have some metabolic issues. We could check fasting insulin. We could look at A1C. We could consider what he's eating. We could look at his body mass index and consider, does he need to lose some weight? That would be another evidence of a metabolic health problem. There's more that we could dig into, but perhaps by improving metabolism, by getting him outside and getting some more sunshine and vitamin D production, maybe by checking his vitamin D3 and boosting that level, maybe looking at B vitamins, since low levels of B vitamins are associated with depression and anxiety and other mental health symptoms, maybe we could make a difference with his depression and consider weaning off an SSRI antidepressant that might be causing some negative side effects. It's at least worth a conversation with his doctor and potentially looking at safe things that could be tried to see if they make a difference for him. Now, what about the rest of his medications? There was a long list of things. So if we look at things like lorazepam, well, that's another psychotropic drug. Seroquel's another psychotropic. Trazodone's another psychotropic. There are quite a few things on that list that are considered psychotropic drugs. And since they're not safe to use in elderly dementia patients, at least not universally safe, what things could we look at that are other clues? Well, here's milk of mag, and that's used in chronic constipation. That's suggestive of gut health problems. Isn't it interesting that he has both Imodium and milk of mag? This guy might be fighting a battle between constipation and diarrhea, neither of which is really good. So again, focusing on gut health problems could be a big deal. If he's using Miralax, that's further evidence of a gut health problem. If he's using Zofran because he has frequent nausea, that again is suggestive of a gut health problem. Maybe we've got some work to do on the gut. He's using Depakote, another psychotropic drug. So this guy has a lot of things on his list, and it's tempting to focus on the psychotropics themselves, but hopefully you're getting the idea that the low-hanging fruit might actually be suggested by some of the non-psychotropic medications and other things that we could observe in him. Now, leaving his case behind and just talking more generally, sometimes people have a real change in their behavior, in their affect, in their mood. And sometimes people feel like, well, we've got to talk to the doctor and we need to see if there's something that can be done. And often that something shows up in the form of a medication. But one of the first things that we need to consider in any case is whether we might be dealing with a situation where we should call it delirium and not just exacerbation of dementia or something else. So, delirium involves a disturbed state of mind or consciousness that's usually acute. It comes on pretty quickly and it's usually transient, so it changes pretty quickly sometimes. And it's often manifest by a new onset state of confusion or disorientation or agitation or hallucinations. That is not the worsening or progression of dementia. And we need to learn to distinguish between the two if we're serving someone living with dementia. So we need to start by looking at how they're performing at baseline. If someone has dementia, then behavior tends to change slowly, almost imperceptibly, and things are unremarkable from one day to the next. It's really when you compare from 6 months ago to the present that it's easier to recognize changes. When we're looking at delirium, things happen a lot faster. It feels like they're occurring overnight, and there's profound change. It's something that's remarkable. It really stands out. So, a few years ago, Randy, our medical director here at A Mind for All Seasons, came up with this acronym to think about areas that we might want to consider that have acute effects. They're more related to delirium. And when we pay attention to them, we often find answers that can allow us to avoid using psychotropic drugs. So he pointed out that the word delirium itself is like an acronym. And that acronym reminds us of some key areas: dehydration and drugs, endocrine problems or electrolyte problems, liver issues or lack of oxygen, injury or intoxication, retention, infection, uremic problems, and medications. So let's break those down briefly. I think many of you were not there when Randy talked about this a few years ago. So first of all, look at dehydration and drugs. Are people taking medications, whether they're prescription or over the counter, that could lead to dehydration? You have to have good fluid and electrolyte levels to produce good energy. So if you're using a lot of caffeine, that's a diuretic. If you're taking in a lot of alcohol, that's a diuretic. What about drug interactions? Or people who have swallowing issues or dementia where they might not either remember to drink enough or they might avoid drinking enough. The most common drug problem involved with dehydration problems is alcohol. And alcohol will wreck you in a lot of other ways as well. It's toxic to every cell of the body. So that's one to be really aware of. What about the E? Endocrine disorders or electrolyte imbalances. If someone has diabetes or they're pre-diabetic, they've got problems with blood sugar control, that's an issue that can really lead to severe symptoms. If you've never been around someone whose sugars are really off, it may be harder to recognize and appreciate this, but once you've seen that, you recognize that really low blood sugar or extremely high blood sugar can have an effect on someone, a pretty profound effect on their behavior. Be cautious if people are using diuretics or they're on seizure medications or they have cardiac medicines as well, because this can affect the endocrine system. The L reminds us that lack of oxygen can be a real problem. And we see that in people that have diagnoses like COPD or they have a respiratory illness, people who are smokers or asthmatics or they have congestive heart failure, heart disease, or a tendency toward blood clots or strokes or heart attacks or sleep apnea. All of these things can relate to low oxygen delivery. And if you're not getting good oxygen delivery to the body, and especially to the brain, you might present with some real cognitive and mental health symptoms. Everybody knows that if you hit your head really hard, you might have cognitive or mental health symptoms. So injury can be an issue. So can intoxication. So let's be aware of that. Retention is an issue. Whether you're retaining urine or stool, that's a problem. So be aware if men have an enlarged prostate or if women have a prolapsed bladder, then you've got issues. Be aware that anticholinergic medications can affect the way that the bowel and the bladder function. And they can have other effects. Anticholinergic medications reduce the neurotransmitter that's most important for memory. It's called acetylcholine. So sometimes people are on bladder spasm medications, which often don't work all that well, but they can have really profound anticholinergic side effects that affect not only memory, but balance and focus and concentration. And that might be worth a conversation with the doctor to consider how the risks and the benefits play out. If someone has an infection, it's likely to affect their cognitive functioning. But too many people just jump to the conclusion, oh, they have a urinary tract infection. Now, I love the fact that people are aware that UTIs, especially in older adults, can have negative consequences on cognition. 26 years ago, at the beginning of my career, a lot of doctors didn't believe that a urinary tract infection could show up as a cognitive symptom. I remember having people from the assisted living community where I used to work going to the emergency room at the request of our facility nurse, and she would ask the doctor to please check their urine. And the doctor would say, well, why? They don't have a fever. They don't have classic symptoms of a urinary tract infection. And the nurse would say, please just check it. I really think that they've got an issue. And they would come back sometimes and say, oh my goodness, they have a raging bladder infection, but they don't even have a fever. And yet they had cognitive symptoms. And instead of just jumping, though, to UTI, be aware that people could have symptoms from a lot of other infections. We've seen things from people that have herpes simplex virus infections, the same virus that would cause cold sores. When that flares, you can get cognitive symptoms. If you have dental infections, that can cause real problems. If you have other types of infections, like an upper respiratory infection, that could show up partly with an effect on cognition and mental health. What about uremic issues? Issues that are affected by kidney function or congestive heart failure, or if you have diabetes or hypertension, or you're using nonsteroidal anti-inflammatories, or if you have electrolyte disturbances. This is a problem where urine can become really concentrated and you can have real problems with that. Finally, medications are something that we need to pay attention to. Look at the newest ordered medication. If someone's mood or behavior changes, and you had a medication that was ordered just a few days or a few weeks ago, the first place to look is at the most recently ordered medication, because you could just be dealing with the side effect from that medication. And yet I frequently see people where there's a medication change, there's a change in behavior or mental health status, and instead of discontinuing the medication that was started, I see people just adding on another medication and then another one and then another one, and it becomes this snowball of problems that people face. Be especially aware of sleeping medications or narcotics or anticholinergics or antipsychotics. These drugs have much more significant side effect profiles, and I'm not saying there's never a place to use them. And every doctor that's prescribing has a thoughtful reason for why they're doing what they're doing. And I'm not trying to be critical of all the good physicians that are trying to do the best work that they can. But if we're advocating for ourselves and for people that we're serving, we need to be aware that some drugs have a higher side effect profile than others. And we need to ask good questions and have thoughtful conversation about it. Now, there's at least one more consideration in all of this. And to illustrate this consideration, I want to share another experience I had with another resident of a long-term care community. This was an elderly woman who was kind of angry at the time that this situation developed. She had recently moved into a long-term care setting. She was a retired American Airlines supervisor, and this gal was used to being in charge. And almost as soon as she moved into the community, they started having a real struggle in that she was up most of the night. And she would go room to room and she would try to evacuate residents from their room. She was worried that they needed to get out of there, that there was a safety risk. And when I first talked to the administrator who brought this to my attention and was looking for some ideas to try, I said, What have you tried? She said, well, we've tried to redirect her unsuccessfully. What else have you tried? Well, the staff tried to lock some of the other residents' doors so that she couldn't go in and disturb them. Now, in some parts of the country, that's not even allowed. So I would never suggest doing that. But it didn't make a difference for this woman anyway. She actually broke off two doorknobs. And by the time they got to her, she was even more angry because she'd been fighting and breaking off doorknobs. So, as we discussed things, it became clear that one of the first places that many people would go in a situation like this is to call the doctor and say, we don't know what to do here. This lady is out of control. She's waking up everybody else in the community. It's a real problem. And most people in this situation would end up on a psychotropic drug. Instead of going down that route, we started talking about root cause issues and the fact that we all become a little psychotic when we're up at night. If we don't get good sleep, things don't function well. Sleep deprivation is used as a form of torture in military operations. It's not ethical and it's a war crime at this point, as far as I understand it. But sleep deprivation has profound effects and can even be fatal. So this woman was in a tough spot because she was not sleeping. And I talked to this administrator and said, one of the reasons that older women struggle with sleep is because they have virtually no progesterone in their system, because most older women don't do any sort of hormone replacement. Progesterone binds to GABA receptors. That makes it very calming. Progesterone is also anti-inflammatory. Some researchers and physicians who treat people with traumatic brain injuries and study TBIs use progesterone to treat brain injuries because it's so anti-inflammatory. And I said, I wonder if using some bioidentical progesterone at night, which would bind to the same GABA receptors that benzodiazepine medications bind to, might be helpful for her. Well, the administrator had a good conversation with this woman's physician and asked about maybe trying this. So the doctor obliged and prescribed 100 milligrams of prometrium. And this is what happened. Within a couple of weeks, she said, I just wanted to provide you with a positive update on my resident who was recommended to begin progesterone. She's been receiving prometrium, 100 milligrams at 9 p.m. every night. The results have been such a blessing. She eats all 3 meals with her peers now. She's much more receptive to redirection and direction. She not only sleeps at night, but also takes a nap occasionally during the daytime. She participates in activities as well. Well, that's fantastic. And the body knows what progesterone is. It doesn't know what the antipsychotic medication is, doesn't know what benzodiazepines are. It doesn't recognize those drugs. There are side effects to those drugs. But she did really well with progesterone, and it was infinitely safer than many of the alternatives that people would turn to. So looking at hormone optimization, I think, is at least one other area that could be considered in many of these cases. So if we go back to the idea of looking at baseline cognitive status and how things change over time, we need to realize that there are also some risk factors associated with aging that make older adults especially vulnerable. Now, I'm going to give those of you who are professionals especially, or if you're a family caregiver serving someone in the home, or if you're getting older yourself and you just want to understand your body and how it works and things to avoid, I'm going to quickly give a list of risk factors associated with aging. As we get older, the body doesn't respond to medication in the same way that it did when we were younger. I'm not going to spend a ton of time on each of these risk factors. You'll have the slides to refer to. But what I'd invite you to do is to look for any scenario that kind of fits your situation or the situation of someone you're serving. And then we'll talk about the risk factors associated with it. So let's talk about health factors that are affected by aging. You see a list here with decreased GI motility and function and the risk of constipation, reduced muscle mass and metabolism slowing down, when your kidney function isn't as good. You don't clear medications as well. If you have impaired liver function, then you have altered medication metabolism. If you have lower albumin levels, if you have less protein in your blood because you're malnourished, then you have less protein for medications to bind to, and that affects how medications affect you. If your immune system is compromised, that's going to affect how meds affect you. If you have altered cardiac function or vascular function, then your body is not working as efficiently. You're not pumping the blood as effectively as you should, and that's going to have an effect on medications and how they circulate through the body. And if you have chronic disease, it affects you. So, to break each of those down just a little bit, as we get older, our GI system slows down a little bit. And that can be affected a lot by having surgery and scarring and infection. It can be affected by protein in our diet or alcohol use. And that slowing of the gut and altered GI function can be affected by anticholinergic medications, can be affected by decreased ability to secrete stomach acid. It can be affected by the fact that our esophageal sphincter might not be quite as elastic. It might not close quite as well. So heartburn might be more likely as we get older. We might have problems with digestion. So we need to be aware that those things can change with age. And that's one of the reasons that anticholinergic medications can become more detrimental as we get older. As we get older, we often see an increase in body fat and a decrease in muscle mass. By the time we're about 50, most of us start losing muscle mass, a fairly significant percentage each year. It takes a lot of effort to maintain muscle mass as we get older. Well, when fat goes up, it means increased distribution of lipophilic medications, medications that have an affinity toward fat. So we talked about statins earlier, but drugs like Valium can also be affected by having more fat stores throughout the body. If you have less muscle mass and more fat, you're actually at greater risk of falling. And you might have decreased motility. You might have a harder time moving around because your muscles aren't as strong. Well, that can affect things because if you're more sedentary and you're not upright, then gravity's not doing its job helping to pull things through the gut. We have to work hard to combat some of those things. As we get older, we also have decreased renal functioning. Well, that means that if the kidneys aren't working as well, we might have a harder time clearing medication. If you look at your lab report or the lab report of someone that just had a checkup and you see decreased glomerular filtration rate, GFR, that's basically measuring the kidneys as a filter. And generally, you want to see a GFR that's higher than 65. If it's getting lower, then that should be a red flag that goes off to say, they might have a harder time clearing medication. So sometimes doctors have to increase the dose of medications that are cleared through the kidneys. And you see a list here on the slide, digoxin, allopurinol, gabapentin, and so forth. So be aware that if their kidney function is going down, maybe some of their results might be affected by having less clearance of those medications. So let's be aware of that. If someone is getting older, they might have diminished liver function, and that can affect metabolism. When there's reduced blood flow to the liver, then you might get issues with an enzyme system that we've noted here on the slide. These are things to ask the doctor about if a person's getting older and some of their liver function tests are diminishing. Albumin is often affected as we get older. Albumin, or protein in the blood, binds to drugs and hormones, and older people often don't get enough protein. And when their albumin to globulin ratio changes and it gets lower and lower, and it's not so close to 2 anymore, then that might affect how medications circulate. Low albumin to globulin ratio is a predictor of poor health. So be aware of that. Look for that. That shows up in basic labs that are done when people have their checkup. If someone has poor immune health and they have a slowed immune response, that's likely to affect how they're functioning cognitively. But it's also associated with changes in the gut microbiome, because when people have health problems, often they end up on antibiotics that kill off bacteria, both the bad guys and the good guys, and that can cause increased gut health problems. When people have poor nutrition, that also is associated with immune problems. There can be disease-specific challenges to be aware of and guidelines related to them. So if someone's a heart patient, they've got congestive heart failure, or they're diabetic, or they've got Parkinson's disease, or they have frequent infections, be aware that there's likely more medication side effects associated with those. And we're not going to spend a lot of time talking through these. I'll just give you these slides so that you're aware. And if you're serving someone with cardiology issues or heart failure, there's a list of medications here to take an extra close look at and have more of a conversation with the doctor about them. Same things for people who are diabetics. You might want to avoid certain medications and be cautious with some. So we've given you some guidelines here on the slide. With Parkinson's disease, avoid antipsychotics because they block dopamine. And diminished dopamine is a real problem in Parkinson's disease. That's why people can't move so well. So that's really tricky because sometimes people with Parkinson's might develop hallucinations. And so you might have a tendency to give an antipsychotic. Perhaps there are other things that can be tried, though. There was a study that came out a few years ago that was a meta-analysis looking at multiple studies done on people who have hallucinations. And the researchers found that when you gave someone who had frequent hallucinations high-dose vitamin B12, after 2 months, 75% of patients have a complete stop to their hallucinations. Maybe it's worth a conversation with the doctor to measure a B12 level, maybe measure a folate level, vitamin B9, maybe measure homocysteine, since that amino acid that's damaging to the brain gets elevated when we don't have good B12 and folate levels, and maybe make some decisions from there. If people have chronic bacterial infections, then there are some risks that go with that. So we wanted to give you a slide to refer to related to that. If people have arthritis, they're in a lot of pain. And sometimes people take a lot of nonsteroidal anti-inflammatories. Well, that can increase the risk of cardiovascular disease. It can increase the risk of GI ulcers. It can worsen kidney functioning. So we've got to be really careful and maybe look for other ways of reducing pain. I know a lot of people who do far better with their arthritis pain when they decrease sugar in their diet because sugar is so inflammatory. I've had a lot of people say, wow, my joints feel so much better when I really dramatically cut sugars. Well, that's a safer thing to do than some of these NSAIDs. There's also a supplement that's been involved in a head-to-head trial against Celebrex, and the supplement uses turmeric. It's called Curamed. The company Terry Naturally makes it. And they did a double-blinded, placebo-controlled crossover trial, and they were comparing Curamed with turmeric in it against Celebrex arthritis medication. They found that it was as good or better than Celebrex. That might be something to try or talk to the doctor about. Now, in the end, I want to share some commandments, and I will give a nod to Randy Vaudry, our medical director. He came up with this idea of referring to it as the 8 commandments of psychotropic drug reduction. And so we're going to reference Moses here, Charlton Heston in the old 10 Commandments movie. Let's talk about not 10 commandments, but 8 commandments for trying to reduce psychotropic drugs in our own lives and in the lives of people that we're serving. So commandment number 1 is to verify that the challenge you're facing is a progression of dementia versus a new onset of delirium. And if you're not dealing with dementia, but suddenly there's an altered state, then that is something to look into related to delirium and all the things that we discussed earlier about delirium. The second commandment is to consider non-drug approaches and interventions to solve the immediate problem. What about assessing the crisis? What about looking at environment? So much of a person's behavior is affected by environment itself. It's the stage that we're on and how people, who are often really confused, are responding to that stage. For example, I've been to a lot of small memory care communities where they might have a living room looking area that's very home-like. If you're completely confused and you have no idea where you are and you're sitting in this room that looks like your living room, and it's just you in that room, you might think that you're home minding your own business. And often in those communities, The front door to the facility opens right up into that living room area. And it's a locked door. It may have a keypad on it or some other locking mechanism so that people with dementia can't just walk out the door. But what happens to someone who's confused, living in the moment, sitting in that living room, minding their own business, thinking that they're home, when suddenly a hospice nurse or a family member or a staff member walks through the front door? That scenario can feel to a confused person the same way that it would feel to you and me if we were sitting home minding our own business and a total stranger just walked in the door. That's more than a little upsetting, and we might fight for all we're worth. And seen through that lens, it's a completely rational response to the situation. If we don't understand how environment is driving behavior, then we might think that people are just off the rails, and although we hate to use it, we might need to turn to a psychotropic drug. Maybe not. Maybe we could do better if we understand environment. We also need to realize that sometimes people are expressing pain in behavioral ways. We see this in children who can't speak yet. Little kids might tell you that their gums hurt because they're cutting teeth by drooling and being extra fussy and biting on things. And young parents very quickly understand, oh, they're just communicating to us that they hurt. The same thing can happen with older adults who might lose the ability to verbally communicate, but they might tell us through their behavior that they don't feel good, they're in pain. If you have someone who struggles a lot with constipation, they might feel like they need to have a bowel movement, but they can't get it out and they're distressed. So just be aware of those things and do the detective work. Commandment number 3, assume that new challenges are a medication side effect, a bad reaction to a medication, before assuming that you've got a new medical condition on your hands. When we assume that first, then we're much more likely to try discontinuing a recently added medication. So go look at the medication record for recent orders, or if it's in your own life and you've got an issue going on, did you recently make a change? Did your doctor prescribe something new? Maybe you're just having a reaction to that. Commandment 4, consider or request lab work before treating with a new medication. Look at electrolytes because electrolyte imbalance can show up behaviorally. Look at a complete blood count. Look at relevant history on the medication record. Again, looking for changes. There's a lot of detective work to do before just calling the doctor and saying, could you prescribe something for this person? They're off the rails. Number 5, request limitations for medications that are not intended for chronic use. That's called requesting an automatic stop date. Most doctors are very willing to do this, where they will put a stop date on a medication. They'll say, let's try this for 2 weeks. They might do that with an antipsychotic or an anti-anxiety medication. Having a stop date ensures that you don't use it very long, that you're just trying to deal with a tough situation, while you also are looking for other alternatives to figure things out. Number 6, inquire or verify any risk for duplicate therapy with similar medications the client is already taking. Sometimes we add medications on top of other medications that actually do the same things. And if we're not really paying close attention, it's easy for that to happen. Part of why I'm bringing these things up is because most of you watching this are not doctors. I'm not a doctor. My background is as an administrator. But to get good at advocating for people, we need to be educated about some of these things. And when we're educated, we are better advocates for others and for ourselves, and we can have more thoughtful conversations because sometimes things just get missed, especially if you have multiple providers involved. Be aware that when it comes to mental health challenges, often we see one mental health medication added on top of another, added on top of another. It's super common that we'll see people with 3 different antidepressant medications. Now, maybe there's a reason for that. And again, I'm not the physician, but maybe we can have a conversation about things like that and determine whether it's actually necessary. The same would be true with managing pain. Sometimes we see a lot of duplicative therapy with pain management. Commandment 7, inquire or consider a medication reduction every time you consider adding something new. In other words, if you're going to add a new drug, especially something that's a psychotropic drug, you better reduce something else or eliminate something else. let's avoid the situation where we're adding one on top of another on top of another, because that becomes a disaster almost always. And lastly, consider the age and the frailty of the individual when you're considering new medications. Some people just rarely tolerate new medications very well at all. So consider how you've done with medications. You know how your body responds. Consider how the other person does with medications. If you're serving somebody and you've observed they don't do well with changes, then be really thoughtful and look for every alternative except for a medication change. Try to do other things first. So, what else can we do? Well, you've probably seen this slide here before. There are a lot of different things that we could look at. We're not going to go into the details of these, but we can pay attention to other root cause issues related to metabolism and vascular health and hormones and nutrients and gut health. We can look at inflammatory markers and what we could do to reduce those. We've talked a little bit about infection, but we could dig deeper into those areas. There are lots of neurotoxic substances that might affect people, and we could look into that. We could take into account their history of concussive injuries and what we might do to help them recover. And we can be aware of autoimmune conditions that affect people. There's actually a very long list of things that we can be looking at for ourselves and for people that we're serving. And when we pay attention to these other factors, we're much less likely to be turning to psychotropic medications. So let's stop the formal presentation here. I appreciate you being here and taking all of this in. Let's have a discussion for a few minutes about what questions you have or what stands out here and how this might apply to you or to someone that you're serving.